I want you to imagine a situation whereby you're on the pediatric ward and the mother comes in with a 3-month-old child and is claiming the child has been irritable, the child is not feeding well, and she thinks even her child is having a big head. You look at the child and obviously you realize the head is actually bigger and disproportionate to the body. And when you measure it, it's above the 98th percentile when you compare with the chart for other kids. So as you're still talking to this mother, the consultant comes in and asks you what you think your diagnosis is and how you would manage such a patient. If that question made you nervous, then this is a video for you. This is made one pager, and I cover high-yield medical topics on a single page. And in this video, you're going to cover the physiology of hydrocephalus. We're going to look at the different classifications, etiologies, the pathophysiology of the manifestations, the different clinical manifestations, both in children and in adults, and the investigations. And we shall end with some of those neurosurgical interventions that are done. We shall look at them. And at the end of this video, I'll give you some important absolute things that you always have to remember about hydrocephalus. So when we look at hydrocephalus, this is a condition where we have a pathological accumulation of CSF within the ventricular system or the subarachnoid space. And this is going to lead to increased intracranial pressure and ventricular enlargement. So when you look at the physiology of CSF, this is very important for you to understand the balance of things and how critical this balance is. When you look at the production of CSF, it's produced by the choroid plexus, and the choroid plexus is going to be found in the lateral, the third and fourth ventricles. And we produce about 0.3 mils per minute of CSF. That is equivalent to around 500 mils per day of CSF. But always the total volume of CSF is going to be 150 mils, which means about 350 mils per day of what's produced is reabsorbed. So the highest amount is reabsorbed, and the secretion is going to be sodium, potassium, ATPase dependent, as well as ultrafiltration. So when this CSF is produced, it's going to flow from the lateral ventricles. It goes through the foramen of Monro into the third ventricle. When it goes into the third ventricle, it will leave the third ventricle through the aqueduct or Sovius into the fourth ventricle, and from the fourth ventricle, it goes through the foramen of Luschka and Magendie into the and then into the subarachnoid space and the spinal canal. So the absorption is going to take place within the arachnoid granulations, and it's going to be pressure dependent. And then we can have some secondary areas where we can have this CSF absorbs, like with nerve sheath, like the lymphatic system, the nerve sheath lymphatics, and the lymphatic system. So in normal adults, the CSF or the normal intracranial pressure is going to be around 7 to 15 millimeters of mercury. In children, it's about 3 to 7. But in young, it's about 1.5 to 6 millimeters of mercury. And by the Kelly-Monro doctrine, is what the doctrine that Monro and Kelly came up with, that says that the brain is a fixed volume, and that fixed volume is going to contain 80% brain, 10% blood, and 10% CSF. So in hydrocephalus, we have a condition where the CSF is increasing more than 10%. And what will happen? This is going to be compensated for by reducing these other percentages to keep it 100%. Now, you don't want to compress your brain. What that will do is going to compress the amount of blood. So when we look at the classification, we have classification by mechanism, and that is the first classification. And we have the obstructive, or what we call the non-communicating. When they say non-communicating hydrocephalus, is a hydrocephalus where the ventricles are not communicating. There is some obstruction between the ventricles, and mostly that is going to be obstruction of the aqueduct or Sovius. In the first case, that is the highest cause. Then we have the mechanism where we have a communicating hydrocephalus. Now, when we are having a communication, the flow, there is no blockage in the flow. Then the problem is at the absorption. You have impaired absorption. This is going to be commonly caused by things like infections, meningitis. Then we have the hypersecretory, whereby we have increased production of CSF, like in choroidal tumors. And then we have the ex vacuo, which is not a true hydrocephalus. So what happens here is that we have the brain atrophying, and when the brain atrophies, the CSF or the ventricles are going to enlarge. and that is going to give an appearance on imaging that will resemble hydrocephalus, but it is not. So it's very important to know that it's not true hydrocephalus. So we can also group hydrocephalus by ICP, where we have the high pressure hydrocephalus, the normal pressure hydrocephalus, and this normal pressure hydrocephalus is common in adults, and it is the one that's associated with the Hakim triad, which is a triad of the wet, wobbly, and wacky. We have someone with incontinence, someone with a bad gait, and someone with features of dementia. Maybe I'll do a video about normal pressure hydrocephalus because it's kind of a different entity and has a lot of important aspects to it. Then we can also classify it by time as acute, subacute, and as well as chronic. So when you look at the etiology, this is very high yield, very important for you to know. We have the congenital causes, and that is aqueduct of sylvius stenosis. That's the most common. We can have the myelomeningeal cell plus a Chiari II malformation. And a Chiari is basically where we have the cerebellar tonsils kind of herniating down into the foramen magnum. So when they're going down into the foramen magnum, they're going to compress the fourth ventricle and things like that. They're going to cause that stenosis. Then we have the Dandy-Walker malformations. Then we have CMV and toxoplasmosis. These are torches. These are congenital infections. Then we look at the acquired causes. We have tumors. We can have tumors like posterior fossa tumors, colloid cysts, pineal tumors, ependymos, ependymomas. We can have intraventricular hemorrhage, especially in the premature neonates. We can have subarachnoid hemorrhage. Then we can have TB meningitis as well as bacterial meningitis. These ones are going to interfere with mostly the absorption of the CSF. So when we look at the physiology, what happens in acute hydrocephalus, we're going to have ventricular enlargement. Now, when the ventricles enlarge, there is going to be the periventricular white matter edema, or what we call the transependymal CSF seepage. We're going to have the ventricles increasing, but they're increasing with a lot of CSF. So the pressure is going to push on those ependymal area, and we shall have CSF going around the periventricular area, giving a kind of edema there. So as the rising ICP occurs, cerebral blood flow is going to be compromised, and this is going to lead to brain ischemia. And when this occurs, sometimes we have an ankle or tonsillar herniation that is going to follow, and if untreated, if we don't treat the rising ICP, we shall have tonsillar or ankle herniation, which is a neurosurgical emergency. And of course, if you do not intervene, death will ensue. Then when we have chronic hydrocephalus that occurs over a long period of time, there is going to be gradual stretching of this periventricular. We are going to have this stretching of the periventricular long white matter tracts, especially in the frontal subcortical circuits. And now these white matter tracts, they're coming from the motor cortex, from the front. Okay, they're coming from the cerebrum, and the disruption of this corticospinal tracts is going to cause issues with gait. Remember, the corticospinal is the tracts that also bring motor information. So we're going to have issues with the gait, frontal connection, and cognition. And then we can have the bladder control circuits also disrupted within there. Then we can have cerebral mantle thinning in severe and long-standing cases. When you do the imaging, you can see the cerebral mantle has thinned a bit. In neonate ones, infertiles, where these situations, there are some specifics, like we have the cranial sutures have not yet fused, and when they have not yet fused, we can have a compensatory skull enlargement. So when this occurs, we have delayed symptom onset. So these people tend to kind of have a delayed onset of these symptoms, and therefore in children who have these hydrocephalus, if you do an early intervention, you can actually help prevent some of the complications that come from hydrocephalus. Then we have periventricular leukomalacia. Risk from white matter ischemia is also high. So when you look at the clinical features that we see in children with in people with hydrocephalus, in infants, you're going to have poor feeding, you're going to have irritability, you're going to have decreased activity, and you're going to be having vomiting. And this is all going to come from increased intracranial pressure. Then when you look at the signs, the head circumference is going to be greater than the 98th percentile, or it's going to be crossing percentiles if you are measuring it serially, you'll see that the head circumference keeps on crossing percentiles. If it was in the 90th percentile, it crosses to 95th. It keeps on crossing percentile lines, then you know something is not going on right. Then you have sutural separation. Now, where the suture is separated, dilated scalp, a bulging fontanelle, the setting sun sign of the eyes, and then you can have increased tone. And this is going to be more in the lower lips than the upper limbs. Then in children or adults, when you have raised intracranial pressure, it's going to be followed by a morning headache plus vomiting. They may have blurred vision due to papilledema and optic atrophy. Then they may have diplopia due to compression of cranial nerve 6. They may have neck pain due to tonsillar herniation, and they may have drowsiness. Then they may have cognitive or mental slowing and deterioration. Then motor may have a spastic gait. They may have a spastic gait. This is going to come from periventricular spinal stretch, and they may have an unsteady gait. Then lately, they may have urinary, and sometimes, rarely, they go to fecal incontinence, and this is due to frontal lobe damage. So we have some specific signs that are seen. We have things like the upward gaze palsy, and that is due to tectal compression, and things like the Pirinaud syndrome I talked about there. We can have things like papilledema. This is going to occur, and it's not going to be an acute thing. So papilledema kind of takes time to set in. We have the McCowan sign. We have stunted growth or sexual maturation, and this is going to occur when you have that ventricle dilating. When it dilates, it's going to push on the solar tussica. When it pushes on the solar tussica, it's going to cause compression of the pituitary. And remember, it's the pituitary that is responsible for projection of this growth hormone. So when you look at the investigations we can do, the first line investigation is the CT, and this is because it's cheap, it's readily available, but other things like radiations and stuff are going to. So what we are going to look at is the periventricular hypodensity, which is going to be due to this fluid around the ventricles. It is one of the signs that we are going to see on CT. Then when we have hydrocephalus, most of the time we do the Evans index, where you get the width of the horns, the anterior horns of those. You get the ratio of the width of the anterior horns over the ventricles to the whole width of the skull, of the cranium inside. And that ratio, if it's greater than 0.30, then you have hydrocephalus. Then we do the MRI, and this is the gold standard, and it's going to show us the transepidermal edema because of its good resolution with soft tissue. It's going to also show us the aqueductal flow, especially when you use contrast. It's going to show us the aqueductal flow. You cannot see the aqueductal flow on CT. So with the CT, you won't know if there is flow of CSF or not. But on the MRI, you can tell that there is flow of CSF. And sometimes it's increased, especially in things like normal pressure hydrocephalus. When, of course, you have non-communicating, it's going to be decreased flow. Then you have a dash pattern and the colossal angle less than 90 degrees. It's going to be also set. Then lumbar puncture can be done, and you have to be careful not to do this in obstructive causes, especially if you have a mass or a tumor going on. If you do a lumbar puncture, this is going to lead to herniation. So it's important that you always do a CT or imaging before you do this lumbar puncture. And the opening pressure is what you're going to look at. And sometimes when you do large volume taps, like 30 to 50 mils in people with normal pressure hydrocephalus, they have some kind of improvement of those symptoms, the wet, wobbly, wacky. Those symptoms are going to improve with large volume taps, and that's going to predict shunt response. If we have improvement in those symptoms, then a shunt actually is going to help this patient greatly. Then it's contraindicated in obstructive hydrocephalus. That's what I talked about. Then we have ICP monitoring, where you can you see the Landberg airways and the Bewers in normal pressure hydrocephalus. In neonates, a transfontanelle ultrasound is a must, and it is the first line. So management, there's acute, and we have the acute where we do head elevation, monitor and hypertonic saline, and urgent CSF diversion, and that is going to be with an external ventricular drain. This external ventricular drain is going to be put through the skull at Kocher's point. This is a very important thing to know for your examination. It's Kocher's point, and it is going to be used in acute cases. Some of the complications is infections and over drainage. Sometimes if you don't, you may remove a lot of CSF and cause over drainage and get what we call a slit ventricle. Then endoscopic third ventriculostomy is one other important thing, management that is done, intervention that can be done, and it is best for aqueductal stenosis, but it's not ideal before 6 months of age. This ETV has some success scores that you have to know that will always give you the prognosis. The complications include basilar artery injury or even failure of this endoscopic third ventriculostomy. Remember, the aqueduct of Sylvius is draining that ventricle. So if it is the one that has issues, go into the third ventricle, do ventriculostomy, and then you'll have the subarachnoid space taken up with fluid. Then we have the shunts, and these are the most commonly done. And we have the different types. We have the ventricular shunts. We have the ventricular. Ventricular is going to come from the ventricle, going to the peritoneum. The CSF is channeled into the peritoneum. Ventricular, the CSF is shunted into the atrium. Ventricular is going to be taken into the pleural space. And you can imagine the complications that can follow this. We can have obstruction occurring. We can have infections ascending, especially this staph epididymis. It's important to remember. Then over drainage can lead to slit ventricle. We can have subdural hematoma. Then you can have pseudosis developing. So most of the times these shunts are revised. 40% are revised in the first year and 80% are revised by 10 years. So the failure is also a bit high. Then we have some newer techniques like the choroid plexotomy, where or plexus coagulation, where the choroid plexus, they go ahead and coagulate it using laser or other things, and to decrease CSF production. Sometimes medical drugs can be used, especially to delay the shunt before the shunt, and that is drugs like acetazolamide, drugs like furosemide, used to decrease this CSF or increased intracranial pressure. So what you should remember for your examination is the absolute examples. The most common congenital cause is aqueductal stenosis. Myelomeningeal cell is going to be seen with a Chiari-2 malformation. When you have normal pressure hydrocephalus, the gait is the first thing that affected. They become nervely fast, then they are going to get the cognitive difficulties, and then at last, then remember the Evans index that is greater than 0.30 is the one that is diagnostic. Kocher's point is the where we press the extraventricular drain. Then staph epididymis is the most common cause of shunt infection, and IIH is equal to raised intracranial pressure plus normal ventricles. Then Cushing's thread is a late sign of hydrocephalus. If you lie on it. So you have reached the end of this video, and I hope now you can have a rough approach to a child with a hydrocephalus. If you enjoyed this video, please leave a like, share it with a friend, and subscribe to the channel if you are not subscribed. And let's meet in the next one.